Hi, I'm Beryl Benassaraf. I'm from Harvard Medical School and the Brigham and Women's Hospital in Boston, Massachusetts, and I'm going to be talking today about 3D ultrasound in gynecology. So what is new in 3D ultrasound of the pelvis, and how do we use it to evaluate the gynecologic patient? Well, 3D ultrasound is really a volume acquisition, and it's done to obtain an image that actually can be displayed in 3 different planes, all of which can be related by one point in space, and then you can navigate through those planes using the dot at right angles to each plane. And the technology enables us to see anatomic sections in an orientation different from the actual acquisition section. And this is an example where you can see we acquired the image transversely transvaginally. You can actually also acquire it longitudinally, but what you can't acquire is the coronal view. You can only reconstruct it and see it after the volume has been taken and worked on. So the 3D is volume imaging. It's very different from a cine loop. It is not operator dependent because you have the volume and somebody else can then navigate through the volume just as though they were actually scanning the patient. So it is much less operator dependent than any cine or individual image that a sonographer might be able to take. And we can then reconstruct the view of the uterus in the very same orientation as a Netter diagram. As you can see here on the right, the Netter diagram is showing the coronal view of the uterus, both cornu and the cervix, and we can duplicate that with a 3D ultrasound. And that is actually one of the best ways to image the uterus that we really haven't had access to with regular 2D ultrasound. So really the most important benefit of 3D ultrasound in gynecology is the ability to generate this coronal view of the uterus and of the other portions of the pelvis and show that coronal view that short of an MRI we would not otherwise be able to demonstrate. And here you can see that there's an IUD within this uterus. So let's look at a couple of, at least more than a couple, of ways in which we can implement this view to help our patients. For example, here are 2 different patients who had an IUD in the uterus, both abnormally located. They came in because of bleeding and pain. Here is the IUD, shaft of the IUD here, and the 2 arms are in the cervix. Here the shaft of the IUD is in place, but one of the arms is really poking into the myometrium. No wonder the patient has pain and bleeding. So where is the IUD here? It's a little low in the uterus on 2D, but in fact 3D shows that both arms are embedded in the lower uterine segment here. And in fact the lower uterine segment is not really wide enough to be able to deploy an IUD completely. And so no wonder that when it's low, it's going to be embedded. Here's another one, again quite low, and again embedded in the myometrium. The uterine cavity can't accommodate the IUD that low. It's not wide enough. Here's another one. Where's the IUD here? Well, we can see that the shaft is in the center of the uterus, a little low, and here are the arms, but what we can't see is where the uterine cavity is. So when we look at a 3D, we can see that the uterine cavity is depicted a little brighter, and the IUD is oblique within the uterine cavity. The uterine cavity really wasn't big enough in this patient to accommodate the IUD. Now here we are with 3 orthogonal planes, and what we have is an IUD that is actually upside down and backwards in a sense, where it's headed actually down instead of up. Very abnormal in appearance. So we actually did a study looking at consecutive patients who had IUDs in place, and turns out that 16.5% of those patients had IUDs that were embedded in the myometrium or cervix. And all of the ones that were low in the uterus were all embedded. And it turns out that if you compare the IUDs that were embedded to those that were not embedded, the patients came in 70% of the time for either pain or bleeding when the IUD was embedded, compared to only 34% of the time when the IUD was not embedded. So most of the patients, when the IUD was embedded, had either pain or bleeding, whereas less than half, or only a third of the patients where the IUD was not embedded, came in for those reasons. And here are some more examples of the IUDs embedded in part, and this is only by a little bit, and I don't know whether this would really be an explanation for pain and bleeding. Certainly those that I showed you before are more severely embedded. So in conclusion, the coronal view is necessary to image the position of the IUD, particularly the arms of the IUD. An abnormal positioning of the arms may result in abnormal bleeding or pain. And you really can't see the arms of the IUD very well without the coronal view. So the question is, are IUDs too big for the average uterus? We looked at the group of patients that we're talking about, some of which had embedded IUDs, and found that the width of the uterine cavity was 32 millimeters across in patients with the IUD in a normal location versus 25 millimeters across for those with embedded IUDs. And it turns out that the standard IUD is 32 millimeters in width, so no wonder some of the uterine cavities were not big enough and the IUD was embedded. Now here is the width of the uterine cavity transverse in a patient with a normally placed IUD versus one where the cavity was narrow and the IUD was not normally located. Now, the question is the uterus too small and does the IUD fit? In this case, it doesn't. It never really got deployed. The transverse diameter of the shape of the IUD when it is opened in a T is 32 millimeters, and only 4 or 13.8% of patients with the embedded IUDs had a cavity greater than 32 millimeters versus 32.6% of patients with a normally placed IUD. So who decided that the IUD should measure 32 millimeters across the top? Maybe there should be smaller size IUDs for smaller patients. And perhaps it might help to do a 3D ultrasound prior to the insertion of an IUD. So these are hard to find IUDs, and here is an IUD which is seemingly in the center of the cavity, but if you look at it in 3D, it actually looks like an anchor because it is actually upside down. Here's another one. Lots of different arms here, don't know which is which, but here you can see that the endometrium is actually quite narrow, the cavity, and we were not able to deploy the IUD fully. And here is a retroverted uterus. Again, where is the IUD? Lots of different branches here. We don't know what's what. Here it is, and one arm is really quite a bit embedded into the myometrium. Now, sometimes we can use the shadow of the IUD. You can see that this IUD has a shadow. Now, that should not be mistaken for the IUD itself. You can back into the IUD using the shadow. Here's another one. There's a shadow of an IUD, clearly misplaced, and we can back into the IUD itself using the shadow. So sometimes the shadow is more obvious than the IUD itself, and we can back into it quite nicely. Now, the width of the uterine cavity in a large number of patients that we looked at is 29 millimeters, and in nulliparous patients it is 27 millimeters compared to 32 millimeters in those with one or more pregnancies. So clearly the more pregnancies you have, the wider the uterine cavity, and no wonder that those with a nulliparous uterus have a cavity that is only 27 millimeters in size. Now let's look at the shape of the uterine cavity. The prevalence of Mullerian duct abnormalities is really quite elevated in those who have infertility, between 3 and 10% in patients who have infertility and recurrent pregnancy loss. So let's look at an example here. Here is a patient who has a septate uterus all the way down into the cervix. And here are two patients, both with Mullerian duct abnormalities. You can see that there is a island of endometrium within the myometrium here. And you can see that these, in fact, are very different. This is an arcuate uterus versus a deeply septate uterus here. And they look the same in 2D. So the 3D was really absolutely necessary here to evaluate the shape of the uterine cavity. And here are two uterine cavities that are both septate. This one has a deeply septate cavity, whereas this one has a rather wide and broad septum, very different in appearance. Now, the bicornate uterus has an indentation at the top of the uterus, whereas the septate uterus has a flat top. And you can see that the uterine cavity looks the same in both of these. And if you did a hysterosalpingogram, they would look the same. But they are very different entities because one is actually a septum and the other one is a bicornate uterus. Here is a view of a uterus which is unicornuate. You can see how the transverse and longitudinal view of this uterus look essentially normal, but clearly the coronal view of the uterus has one single horn. When you have a unicornate uterus, you can have sometimes a rudimentary horn which may not be connected, as you see here. And here are two different uteri, one here showing a small rudimentary horn which is connected to the unicornate uterus. Here is a second horn which is actually not connected, and that would be a situs perhaps for an ectopic pregnancy, which would be damaging. And here is another example of a complex uterine shape abnormality with, at the top here, you have an indentation of the serosa, so this is bicornuate. It's also a complete septate uterus with two cervices. Here are the two cervices with a little bit of fluid in each cervix. So a very complex abnormality, which we can really depict very, very nicely. Now here's a patient that had a rather broad and shallow subseptum, and there was a fibroid right in there, and she underwent surgery, and so we get to take a look after surgery to see whether they were able to shave down the entire septum, and in this case they were. The top of the myometrium here is a little bit ratty, but it is actually fairly straight, so they successfully removed the septum. Now here is a T-shaped uterus. You can see the T-shape of the endometrial cavity, and this was typical of DES daughters. Luckily now that's mostly a thing of the past, in that DES daughters are now largely postmenopausal and no longer reproducing, because the T-shaped uterus is really not compatible with having a normal pregnancy. Most of the time they don't get pregnant, and if they do, they miscarry very early on. Here is a uterus that is severely scarred. You can see on the 2D that there's an indentation here, and on the 3D you can see the scarring in the cornu here, probably from multiple DNCs and perhaps prior pregnancies. Here is also another uterus with a calcification, and in 2D you can't really tell where this calcification is, but in 3D, when we can depict the uterine cavity, you can see the calcifications are in the endometrial region, in the region of the cornu. Now the fibroids are best seen in the reconstructed views. You can use the endometrium as a contrast media. Here is a fibroid. It's located within the cavity in part, but with 3D you can see exactly where it is, how far into the cavity it protrudes, and where exactly in the cavity it sits. Here's another one. Is this fibroid submucosal or not? Let's take a look at the 3D, and sure enough, here is the uterine cavity, a little lighter in color, and there's the fibroid. The fibroid is about a third of the way into the endometrium, so it's partly submucosal, and you can also see the space behind the fibroid in case this fibroid gets resected using hysteroscopy. You can tell that there is some myometrium outside the fibroid. Here's another rather large fibroid. Is that intramural or submucosal? The coronal view will show you that it is clearly intramural and not submucosal, that the triangular shaped uterine cavity is intact. If you do sonohysterography, by all means, do it with 3D ultrasound because you can put some fluid within the uterine cavity, and rather than having to take a whole bunch of pictures one at a time, you can take a volume and then reconstruct that volume later and be able to view the polyps or whatever else is inside the uterine cavity while you just rescan the volume once the patient is gone. In this image, you can see a rather large polyp in the cornea, near the cornea here, and you can see that the rest of the myometrium is relatively smooth except for one little area down here. Now, this is what you get on a normal sonohystogram when you acquired it transversely. I have the dot right here, which is the intersection between all three planes, right here and right there. And you can navigate through this entire volume live after the patient is gone, right on your laptop, and view every single part of the endometrial cavity as though you were actually scanning it de novo. And here is what happens when you have a polyp inside the cavity. You can see the dot is on this little polyp, which is inside the cavity and well surrounded by fluid. You can also render the inside of the cavity and demonstrate that polyp on the coronal view. And here we're also actually seeing part of the catheter that is inside the uterine cavity. Here's another patient who had a thickened endometrium. You can see that not only was it thickened in regular 2D here, but it was also heterogeneous and abnormal. Having put a little bit of fluid in, you can see that there's multiple polyps. Here we're just measuring one polyp, and normally you would have to take quite a few pictures to get all these polyps measured up. But if you take a volume, you can display all of the polyps all together or one at a time, whichever way you want, after the patient has gone, and you can remeasure and re-image those polyps nicely. Now, looking at the adnexa, 3D ultrasound is also very helpful in the adnexa. In this case, we had multiple cysts in the adnexa. Is this the hydrosalpinx, or are these multiple cysts? And sure enough, in the reconstructed view, you can see that this is a hydrosalpinx. The hydrosalpinx is in a plane other than the planes that we could image in, but it certainly was a plane that we could reconstruct. Many hydrosalpinges, however, are out of plane. They're really not in any one given plane. So what you can do is get your complete acquisition and then use an inverse mode where everything that is cystic within a volume becomes opaque, like a cast, and everything that is solid melts away, and then you have a cast, or anything that's cystic, within that volume. And in that case, you can see a rather large hydrosalpinx with a very large cystic area at one end of the hydrosalpinx. So this is not an ovarian cyst, this is a hydrosalpinx. And here are two other patients. These are separate patients. Here's one where we thought maybe there might be a hydrosalpinx here. Here's another one where we couldn't tell. Perhaps that was part of a hydrosalpinx, but we couldn't tell where the ovary was. And in fact, both of those were hydrosalpinges, as you can see on the inverse mode. When you are scanning the pelvis, remember that you also can take a look at the bladder. And in this case, these are two different cases. We have a lesion in the bladder right here and right here, which is irregular and very sessile in appearance, and these are bladder carcinomas. And this is a patient who had perineal pain, and as we put the probe on the perineum, looking down at the vagina here, and this is part of the uterus, this is the bladder, you can see the lesion right here. There's a cystic area surrounded by a thick rind right here and right there. And so we can take a 3D of that and have a look at where we put the dot right here and right there and right there, and you can see that this is a lesion which is right next to the urethra. As we look at the floor of the pelvis, this is the vagina here and this is the rectum, and this is a a urethral diverticulum next to the bladder. So the ability to see the reconstructed planes as in the pelvis is really key to developing these imaging techniques. And I believe that 3D ultrasound has a lot more to offer a GYN patient than an OB patient, and I suspect that 3D will be used routinely in gynecologic patients because we know that it is so much more useful to see the uterus and the adnexa in these reconstructed planes. 3D has been used in CT and MR for years, and now we can bring ultrasound into the era of other forms of cross-sectional imaging. Thank you very much.